Those of us here at Colorado State University are proud to share with you this session of Endoscopy Talks. When you're looking for inspiring veterinary CE experiences, think CSU Vet CE. Nestled up against the Rocky Mountains in our new State of the Future facility, we invite you to experience what we call CE Elevated. We'd love to see you in one of our future on-site, online, or blended courses. Check us out at www.csuvetse.com. Now, please enjoy Endoscopy Talks.
Hello, everyone. I'm Dave Tweed from Colorado State University, and I'd like to thank you for joining us on behalf of Colorado State University's Translational Medicine Institute. So it's a great treat to be joined by Dr. Alex Gallagher. Alex is a graduate of the University of Florida, completed a rotating internship at Virginia, Maryland Regional College of Veterinary Medicine. He spent 2 years in private practice and went on to do an internal medicine internship in a specialty practice. He returned to Virginia, Maryland and completed a residency in small animal internal medicine. Dr. Gallagher is currently assistant professor of small animal medicine at the University of Florida. He's also president of the Veterinary Interventional Radiology and Interventional Endoscopy Society and a member of the Veterinary Endoscopy Society. Dr. Gallagher is going to share with us his experiences in interventional uroendoscopy, performing such procedures as ectopic ureters, urethral stenting, and lithotripsy. So without further ado, I'll turn the session over to you, Alex.
Thanks so much for that introduction, Dave, and it's great to be here tonight. I'm excited to talk about a topic that I really enjoy doing, which is a lot of interventional work. And tonight we're gonna focus on interventional uroendoscopy. And with any of our interventional procedures, besides just endoscopy, we're usually using a lot of other imaging techniques. And so we're going to see some fluoroscopy in here as well. We'll talk about some other imaging that we use to get us to a diagnosis in some of these cases as well. As Dave mentioned, we're going to talk about three main procedures tonight. We're going to talk about cystoscopic laser ablation of ectopic ureters, and then we'll transition to ureteral stenting for benign obstructions. And then we'll finish up by talking about laser lithotripsy, which is one of the procedures I find a lot of fun to do, and we'll get and talk about that. So to start, many of you, I'm sure, are familiar with ectopic ureters, and at least the concept of the anatomy that we're talking about, but just to quickly review that, normally our ureter comes from the kidney and it attaches and empties here in the trigone region of our bladder. And when we have at least an intramural ectopic ureter, we see that that ureter comes down and attaches at the trigone region of the bladder, but then it tunnels through the proximal urethra and can empty really anywhere. So it can empty in the proximal urethra, mid, distal urethra. It can empty into the vestibule. If we have an extramural ectopic ureter, those are going to completely bypass the trigone and can empty either further down the urethra, they can tie into the vagina. So a number of options that those can be. When we look at most of our ectopic ureters, most of these are going to be intramural. And I'd say the majority of the cases certainly we deal with, greater than 90% of them are intramural in their anatomy. And these are the ones that we're able to correct with our cystoscopic laser ablation. When we look at extramural ureters, in the published literature, you can find anywhere from 0 to 31% in different studies in terms of an incidence of extramural ectopic ureters. I'd say in our practice, and it seems like talking to most other people, really we're looking at less than 10% of these. But these are ureters that still have to be corrected surgically. We can't correct those endoscopically. And so it is important to be able to identify those, and we'll talk a little bit about that in the coming slides. Now, we look at cases overall, on average or median, really, about 50% of these are going to be bilateral cases. So we're dealing with both sides being ectopic. When we look at diagnosis, traditionally it relied on ultrasound and on contrast excretory urography. Sorry, hard one to throw out there tonight, based on traditional radiography. And what we found is that's diagnostic in only about 60 to 70% of cases. And it's just a little bit of limitation on really being able to see the anatomy clearly with those technologies. I still do like ultrasound in my cases, mostly to evaluate the upper urinary tract, so particularly the kidneys and the ureter as it courses to the bladder. But these days, mostly rely on CT, and I almost exclusively use cystourethropy really for our diagnosis of our ectopic ureters. And part of the reason for that is if I've got a high suspicion of an ectopic ureter in my patient, and most of these are going to be intramural, then if I get in with my cystoscope, I can make a diagnosis and I can correct the ectopic ureter at the same time. So we can do everything under one procedure and at one time. And if we look at the literature, CT and cystourethropy are diagnostic in about 95 to 100% of cases, and generally are fairly accurate for identifying intramural versus extramural, with a few exceptions there. Now, when we look at CT, and there's a lot of ways to do these, the protocol that I like for doing CT scans when we do them in these patients is to put the patient in ventral recumbency. And we place a urinary catheter that we drain the bladder, pull it back into the urethra, and then add air as a negative contrast agent in our bladder and our urethra. That allows contrast that's coming down from our ureters and emptying into the bladder to settle out ventrally and away from the trigone region where we'd expect our ureters to be entering. And so as you can see in this normal patient, here's a normal ureter, kind of a J hook down in and emptying into the trigone region of the bladder, and it makes it real easy to see. If we flip this patient over and we scan him in dorsal recumbency, all this contrast is sitting in this trigone area, and it makes it a lot harder to delineate the anatomy. And to show that a little bit better in a clinical case, I've got here an axial, a coronal, and a sagittal section of a dog that we've done this technique with. Unfortunately, his bladder was kind of a little tilted up, and we got a little bit more contrast back here in the trigone region than we wanted. But we can clearly see where this ureter is coming down, entering and traveling along the wall into the urethra area here. So we're just beyond the trigone. We can clearly see that there. Again, here we can see this ureter coming, going past the area I'd expect it to enter and continuing on. Again, not as easy to see here, but again, a clear indication that we've got what appears to be an intramural ectopic ureter. So this protocol really gives us a little bit better look at that anatomy there. Now, from a cystourethropy standpoint, when we first get into the vestibule, and orient you in all these endoscopic pictures, we always do our patients in dorsal recumbency. So ventral is going to be at the top of the screen, dorsal at the bottom. Here we have our vaginal vestibular junction, and we see this band of tissue, which is a paramesonephric remnant. And when we go in and we see that band, there's a pretty high likelihood that this patient is going to have an ectopic ureter. So we're going to start looking around. Now, here's another example of a paramesonephric band covering up the vaginal vestibular junction. And notice how this band is really dragging open our urethral papillae here, okay? And then we've got this little hole here. And sometimes this is going to be your ectopic ureter opening. Sometimes you'll see some other openings around here, and this is where we get our guide wire. We'll talk about those in a moment. And we start poking and prodding and seeing where some of these holes lead to. This one actually led through, you can see a little bit of irregular tissue here just past the urethral papilla and the distal urethra. And this was actually a hole that led up to here. And then we had a span that was open, and the ectopic ureter now is actually opening up here. There was a span of tissue that ruptured and went away at some point. We oftentimes see that when we have such narrowed or stenotic openings of the ectopic ureter, that pressure builds up over time. And if we've got a very thin membrane in here, that tends to rupture. And that can create multiple fenestrations. And I'll show you an example of that later on. Now, often this is a common view that we see once we get into the urethra. Again, ventral's up top. This is our actual urethra here. This is our ectopic ureter. And we see this nice opening. And these are pretty easy for us to tell that they're likely intramural because we can actually see that wall that's dividing these. And so it gets good imaging for us here to see what's going on. Now, sometimes they're not quite as easy to find. This is the opening of the ectopic ureter in this dog, and we can just barely make out little wisps of urine coming out of here. I'll play this again real quick, and you'll see up in front of this, you'll see the tissue bulge a little bit because as the peristalsis of the urine comes down through here, we get some distension, a little bit of this membrane. That's a little bit of a clue to us that we've got an ectopic there, but it takes sometimes a little bit of digging on these, unlike that one I just showed you, in order to be able to find this ectopic ureter. Now here's an example of a ureterocele. So this is a kind of a big distended out area of the ectopic ureter that we call a ureterocele. This is sitting right at the trigone region. and extending out as our ectopic ureter goes out the urethra. And you'll see how translucent this membrane is. When you back up here just a moment here, you can see how easy it is to see through that membrane. Now, one of the other things we can see is having a very large, basically mega ureter. And here we've already got our rigid scope way up in the ectopic ureter. We're kind of up near the bladder. And so this is where it's hooking around to attach to the bladder at the trigone. As we pull out here, you can see how big this ectopic ureter is. And we come back and we're going to come out through just this little slit here. And again, this was probably originally a much smaller slit, created some degree of stenosis, and that resulted in this dilation of the ureter. And we have a ureterocele here as well. So how does cystoscopic laser ablation work? As I tell my students, it's a little bit kind of smoke and mirrors here, or if you like to watch a lot of HD TV, it's kind of going from that closed in house to that open concept feel. So here's our ectopic ureter coming and going through intramurally through our urethral wall. And what we're going to do is come in with our laser and we're just going to take away that wall. Again, kind of the open concept feel. Now that we've taken away that medial wall, our ureter is now coming down and emptying where we want it into the trigone region of the bladder. Now, this is why this only works for intramural ectopic ureters, because we have to have this outer wall here. If we have an extramural ectopic ureter that comes down and just inserts on the urethra, we can't do anything with that with the laser. Those have to be surgically corrected. Equipment-wise, fluoroscopies, a must for these in order to be able to do some contrast studies and know whether we have intramural versus extramural. Endoscopes, most often we're using rigid because we're mostly doing female dogs, but we can use a flexible ureteroscope for doing male dogs, or convert that male dog via perineal urethrostomy approach to be able to get a rigid scope in just ventral to the anus and directly into the urethra that allows us a little bit better maneuvering when we have a rigid scope versus a flexible scope. As I mentioned, we need guide wires, and these guide wires can be useful for us to kind of poke and prod around holes and openings in parts so that we can figure out where our ectopic ureter is opening in some cases when it's not so clear to see. It also allows us then to feed ureteral catheters into these ectopic ureters so we can do our contrast studies. Obviously, we need a laser, and my preference, and maybe because it's the only laser I have, is using the Homium YAG laser. And we have the Storz Calculus 2 laser, and that's been a great workhorse for us for about the last 11 years and held up really well and does a great job for us. We also use this for our laser lithotripsy we'll talk about, as well as some other procedures we do with the laser in other areas of the body. There's a lot of people who favor a diode laser for this procedure. Those who favor it feel like they get less bleeding and less tissue swelling with doing the diode laser. I found that certainly hemorrhage usually isn't much of an issue for us with the Homium YAG. I will agree sometimes we can get some tissue swelling. And David Sobel actually did a nice talk on lasers in veterinary medicine back. I think that was in the fall, one of the earlier endoscopy.com talks. And I encourage you to check that out because there's some great information about lasers in that talk. And then we're going to need some contrast, and we're usually going to dilute this 50-50 with sterile saline in order to do our contrast studies. In order to prep our patients, we're going to do a CBC in chemistry, just checking overall health, making sure we don't have a patient that's azotemic, that maybe has renal dysplasia on top of having an ectopic ureter. And I can't stress enough having a urinalysis and a culture prior to doing these. And to show you where things can go wrong, so this was an ectopic ureter one of my residents and I did a number of years ago. This is how things looked when we finished the procedure, and we had done a urinalysis and didn't see any obvious infection on there. We had done a culture actually that didn't grow anything. But then the dog came back a couple weeks later, severe stranguria, hematuria, and we ended up finding encrusting cystitis. And this dog had a Corynebacterium, which is slow growing on culture. So that's why our culture was negative. And we went back and looked a little more closely at our urinalysis. And back before we did the procedure, actually had an increased pH of about 8.5. And there were a few bacteria that were seen in there, but no pyuria. And so likely we had this infection brewing there and didn't realize it. On top of encrusting cystitis, if we've got other types of infection, we can end up with granuloma formation around this tissue bed that we've cut open, and that can result in occlusion of our ureters. So we always want to make sure that we have either no infection, or if we have an infection there, that we get it under control. And often these dogs with ectopic ureters have recurrent infections. And so we end up culturing them, getting going on a treatment plan with antibiotics, reculture them, and if they're negative while they're on antibiotics, we get them back in while they're on antibiotics, do the procedure, and we keep them on that antibiotic for a couple of weeks afterwards. When we look at the procedure itself, this is our interventional lab that we have here at University of Florida. As I mentioned, we put all our patients in dorsal recumbency here. This is one of my colleagues, Dr. Chris Cook, and she's got this patient all draped in, getting our sterile table ready with our scope and camera, getting some of our catheters and our bowls for a contrast and everything ready. We've got our C-arm, which will move in position so that we can use fluoroscopy and endoscopy at the same time for these procedures. Once we get in there, we're going to take our guide wire and we're going to insert that under endoscopic and fluoroscopic guidance into our ectopic ureter, pass that up to the kidney. That'll let us know too which kidney does this ectopic ureter belong to. Sometimes it's obvious, sometimes you're a bit surprised when you pass that guide wire where it actually ends up. Over that guide wire, we then place a ureteral catheter, and that's going to allow us to do some contrast studies. And when I first started doing these, I thought, well, shooting cross table and doing a lateral radiograph will make more sense. And so I'm going to show you that, and then I'm going to show you what we do now with actually doing a VD view. But this patient's actually in ventral recumbency on the table, but I flopped him over, or her over, excuse me. So things are up top here, but gravity-wise, you'll see that this is gravity dependent up top here, cranial caudal. This is a ureteral catheter that we already have in about the mid ureter on this patient. And when we do our contrast study, you're going to see the contrast flow down. We see the little J hook. This is where our ureter should be opening. And you'll see the contrast extends down beyond, goes and opens in the urethra. And now we're just getting backflow of contrast into the bladder. Nowadays, we do these in DV projections. And we get to see a little bit better the kidney and keep an eye on that, make sure we're not over distending the kidney when we're doing our retrograde ureterogram. And here we've already done our ureterogram and we're starting to do our cystogram so we can distend out the bladder, really see where the trigone is and see what the anatomy is here. And as we play this video, you'll see me starting to move the tip of the scope around. And what I'm looking for is to see whether or not this ureter and catheter move together with the urethra. And we see this thin band of tissue here that's separating our two lines of contrast that tells me that this is an intramural ectopic ureter. If I start moving this around and I see that this gap here starts getting bigger when I move the bladder over, that usually suggests that maybe we've got an ectopic ureter and our ureter doesn't actually connect to the trigone. Once we're ready and we've decided that it's an intramural, we can get going with lasering. And again, this is our homeomyag laser, and I'm using this catheter as a guide. So I know which direction that I need to cut in and where this ectopic ureter is going. And this one's going to be heading up over to our left side over here. Again, ventral up top, dorsal below. Right's going to be to the left side of your screen, and this is going to cut up over to the left. And you see the homeomyag does a good job using it in a non-contact way. If we get contact with that tissue is usually when we start to get bleeding. Here's another ectopic ureter, and this one was much longer, running right along the dorsal aspect of the urethra, so it was real easy to get a catheter in. It's pretty thin membrane, easy to see that catheter. You can see where we have an extra rent here where this ectopic ureter actually had multiple openings. And it's important that we really look and see where's the terminal opening of this, because when we're doing this, we want to try to get this entire tunnel open, and we're going to carry this cut all the way up and into the bladder. When we go back and repeat our contrast ureterogram, here we're going to see now as we do this that our contrast comes down and now we're emptying straight into the bladder. This one is emptying a little bit more caudal than I wanted to. So after this, we actually moved it back up here a little bit closer to where we can see this coming in. But once we're in front of that vesicular urethral junction here and we're dumping into the bladder, that's really our main goal of things. Here's what we end up with the final product. So here's our normal ureter. And we're using that as a match for where we think our ectopic ureter should open in comparison also with our contrast study. You can see we've got this nice open trough here. And this is a different dog, but showing you what this looks like a couple of weeks after we've done the ectopic ureter ablation. And this dog's actually got bilateral ectopic ureters. So that's why this looks a little bit abnormal and raised here. And then we're going to come back and see our other ectopic ureter a little bit further back. But we've got very nice healing here. We've got both of these emptying into the bladder. and we're real happy with how this turns out. Now, sometimes we run into complications, and we've mentioned infections and granulation tissue or granuloma formation. One of the other things we can end up with is perforation, and this is a digital subtraction ureterocystogram. And you can see the contrast leaking out here. I'm going to play it one more time. We can see right here at the junction where the ureter is coming into the bladder, we get a leak. And just to show you that in kind of a static picture here, you can see this contrast coming out. And this was an ectopic ureter that we had moved in, and it was in the bladder, and it was totally fine where it was at. And I said, well, maybe it could be just a little bit more further forward. And I started cutting a little bit more, and then started to see a little bit of black through the tissue. And that's when I went, uh-oh. And we did this contrast study. And fortunately, this dog did great. We kept it in the hospital for 24 hours. We just took it out frequently to pee, and it was pretty small hole, sealed up fine. Dog did fine. Funny enough, about 2 weeks after this, I was at the ACIM forum, and Dr. Allison Brent was talking, and she had a great line. She said, "The enemy of good is better." And I instantly thought of this case, and that's something that's stuck with me since then. And so if things look pretty good, oftentimes you're better off just leaving it and not trying to get better, because sometimes that just gets you into trouble. In terms of post-op care, we'll usually continue these patients on antibiotics either as a prophylactic treatment for 10 to 14 days to prevent infection after we've done this lasering. We have this open tissue that's healing, or if they've already been on treatment, we're going to continue that. Some NSAIDs for pain and inflammation, usually 3 to 5 days. Monitor, make sure they're able to urinate, and most of these dogs are going to go home on the same day. About 50% of these dogs that we do cystoscopic laser ablation for correction are going to be continent, and that's pretty similar to surgery. And those that aren't continent, we can add on the usual medications, whether that's PPA or estrogen supplements, and that gets you up to maybe 65% or so of these patients being continent. And then for those that are still incontinent, we can do other methods such as bulking agents or placement of urethral occluder devices in order to get these patients totally continent. All right, Dave, I'll pause here. Let me know if we've got some questions so far on that.
Yeah, actually, you've answered a couple of those questions already.
Excellent.
One is a question about, and I think you sort of talked about granuloma, but stricture formation at the ureteral opening in the bladder after you, take it up to the bladder.
Yeah, unfortunately, we've been looking and talking to others as well. That tends to be a pretty rare phenomenon. And most of the time when that's occurred, it's associated with infection that happens either was there and missed at the time that we did the initial procedure or has occurred later on. And we've had this one dog that's developed the encrusted cystitis and actually obstructed the ureter. I've had some colleagues that have had granulomas that have formed there, and they've always been associated with infection. I think as long as you take care of that infection ahead of time, then it's a pretty low risk with it.
Another question is, if you have a ureteral seal, can you just open that up? Is that right?
Yeah, we basically kind of take the roof off. And so some of these, depending on the size of your ureteral seal, some you can just take up and open up just like you do a regular ectopic ureter. If it's fairly big, like the example of that first one I showed that was pretty big, what I'll do is go up there and almost do a circumferential cut around the edge margin of that to ablate and remove all that tissue. So we have just a very thin flap of tissue out at the margins, and that'll heal up, and that's not going to cause us any issues.
Yeah. And I guess my question is extramural ectopic ureters entering into the vagina. I know that's been reported, but I have never seen one. I don't think we've ever had one at Colorado State University.
Yeah, I've not seen one either. Again, I'm going mostly by, as you said, the literature, and they're certainly reported there. I think some people reported some fistula formation between the extramural ectopic ureter and the vagina, so it's still entering into the urethra, but there'll be a fistula that forms between the ectopic ureter and the vagina. I know people anecdotally have talked about that, but I agree. I've not seen one that directly enters into the vagina, but it's out there in the literature.
We had another question just come in. Why holmium YAG and not diode laser?
For me, the most simple reason is I don't have a diode. So that makes it an easy choice for us. One of the reasons I like the Home Mag is it's been versatile for us for other procedures like laser lithotripsy. We also use it for airway procedures as well. I've been happy with it. There are pros and cons of that versus the diode laser, and there are certainly times I'd like to have the diode. I know some of the folks out there, I know Dr. Allison Brent really likes the diode laser for the ectopic ureters, and she feels like it cuts very smoothly. They don't really get any bleeding, and she feels like they get very nice edges left from where they cut with it. I don't actually have any experience myself, but I'd say it certainly would be a reasonable laser to use for this based on other people's experiences.
Okay. And one more question just came in. With 50% incontinence, is this a barrier to getting clients to agree to this procedure?
Not really, because again, it's the same incontinence rate that's reported basically with surgery. With the exception of there's a more recent study, maybe 2 years old now, that came out of Europe where they had a pretty high success rate with surgery. But some of those dogs, it seemed like were also on medications at the time. But I think their success rate with surgery was around 70% or so, if I recall right. But most of the other studies end up being give or take around a 50% with surgery. And in this instance where we can do this procedure and not have to put the patient through a surgical procedure where we have a abdominal incision that has to heal, we have a bladder incision that has to heal, we can send them home the same day. And oftentimes for us, this is probably less expensive than doing surgery, at least at our facility. And so most owners are more than happy to do the laser lithotripsy.
Good. That's it for now.
All right, great. We will move on then, and we're going to move to talking about benign ureteral obstructions. And causes of benign ureteral obstructions that we see most commonly are stones or strictures. We can occasionally see them associated with spays where the ureter has incidentally been ligated during the procedure. Fortunately, we don't see those too often. The other one that we're going to talk about is a disease called pyelonephrosis, which is really a combination of having an infection in the kidney, a pyelonephritis, and then developing an obstruction on top of that that results in essentially an abscess in the kidney. So we're going to talk a little bit about those, and most of this we're going to talk about focusing on dogs to some degree because those are the ones that we're going to manage with interventional uroendoscopy versus a combination with surgery as well. Now, most of these patients with benign ureteral obstructions, if it's unilateral, they're usually not azotemic. Some of these end up being incidental findings due to other reasons. Some of them may be patients that are acutely painful or have an uncomfortable abdomen that we may find them that way. In patients that either have bilateral obstruction or that also have contralateral disease in the other kidney, those are more commonly the ones that present that are azotemic and sick for us due to their kidney disease. Now, consequences of ureteral obstruction predominantly are a decrease in GFR, and this happens fairly quickly over the first 24 hours of obstruction. And in models of healthy dogs with acute ligation of the ureter, and these dogs are studied, we know that after 7 days of complete obstruction, we have about a 35% permanent loss of function in that kidney. And after 14 days, we have about a 54% loss of function. Now, these dogs, totally healthy, very acute ligation of it. We don't know how this compares to dogs or cats that oftentimes have some degree partial obstructions or intermittent complete obstructions that come and go. And so we may have more time to deal with these and still regain a significant amount of function. We also know that in these studies, if they ligate a kidney and then unligate it, see how much function comes back, and then they come back several months later and take the good kidney out on the other side, the function in these kidneys that were previously ligated actually goes up. And so some thought is that in particularly cats with chronic kidney disease where we see unilateral obstructions is that when we obstruct that kidney, we may be getting more back than what these numbers would suggest because we have disease in the other kidney. And so we may have some hypertrophic effects that help improve and get us better return of function in that ipsilateral kidney that we unobstructed. There's a few different approaches we take for ureter obstruction. The first is doing medical therapies. And these include things like IV fluids, mannitol glucagon cerease, using medications for ureteral relaxation or dilation, and then pain medications. And what's been found so far in the studies that have been done, and we don't have a real great study looking at these, to be honest, but in the information that we have would suggest that these methods are successful less than 15% of the time, and most of that data is coming from cat studies. So while it's something we can certainly consider, um, at least in our practice, if we're going to do medical therapy, we'll usually try it for 24 or maybe 48 hours, because again, that clock's ticking in terms of how long has this patient been completely obstructed, and how quick do we want to try to get to that and unobstruct that kidney in order to maximize our return of function. So we don't necessarily have to go in immediately on these, but we also don't want to sit on for days and days and wait and see if some IV fluids and prazosin work. So for years, our main management otherwise has been surgical, doing either ureterotomy or neocysto-ureterostomy. And these have had variable outcomes depending on whether we look at cats or dogs. And certainly, as you can see in these numbers, cats don't tend to do as well in the morbidity and mortality categories. Dogs do reasonably well, but still have some issues there. And we know, at least from the human side, that a lot of the approach to ureteral obstructions has really gone to minimally invasive interventional techniques. And a lot of this is doing ureteral stenting. And so that brought about doing ureteral stenting in both our cats and our dogs. What we found is ureteral stenting is a little bit more problematic in cats, usually involves a surgical approach in order to do that. There's still some issues that come up with that. And depending on what your experience is with these, some people will still do ureteral stents. A lot of people have switched to doing the subs or the subcutaneous ureteral bypass devices. And I think some of this just comes down to, depending on whose hands the case is in, how their outcomes have been with these two. And so still a lot of debate which may be better. And I think in certain situations, one's better than the other. But tonight we're going to focus on ureteral stenting. And again, mostly focusing on the dog, because that's the species that we tend to do these endoscopically. Now, in the dog, most of these we're going to place endoscopically with the exception of neoplasia, which would be a malignant obstruction in those, because when we go into the bladder cystoscopically, you really can't identify the UVJ in order to be able to pass that guide wire and a catheter to get access to the ureter. So we do a percutaneous technique from the top up, puncturing into the kidney and come down. But in benign ureteral obstructions, we can do these endoscopically, but you always want to kind of be prepared for the option of surgery, because some of these we go into and we try our best endoscopically and we can't get a guide wire to get past an obstruction, or we get some other complication and ultimately we need to convert to an open surgical procedure. So you always want to have that in the back of your mind there. In terms of complications, about 13 to 60% infection rate after stenting, but that's also compared to a 60% pre-op infection rate. So a lot of these are ones that were already had an infection pre-op. The infection's still there post-op, which isn't necessarily a big surprise. And about 10% of dogs will develop stent occlusion. And one of the benefits of endoscopically stenting them is we can also endoscopically remove that stent. And so if we run into problems with infections, if we have stent occlusion, if we only need a stent for a short period of time to get a stone to move and relieve that obstruction, or as we'll talk about with pyonephrosis, then we have an option of putting something in that we can go back later and take out pretty easily. Now, when we do these, this is a nice case. This was, I think, actually one of the earlier cases I did in endoscopic ureteral stenting in. Still one of my favorite cases for a number of reasons. And this was Angelina. She was about a 3-year-old Dalmatian who presented to us. She had had an acute onset of abdominal pain, not feeling well, being a little bit off her food. The referring veterinarian had taken some radiographs and really didn't see anything, so he referred it to us for ultrasound. On ultrasound, we found dilation of the right kidney, and this is about 1.5 centimeters. And we know from a couple of studies that a renal pelvis that's dilated that much most likely is going to be due to an obstruction somewhere. And so with ultrasound, we follow that ureter down and we find this stone in the excuse me, in the ureter that's causing our obstruction. Now, being a Dalmatian and a stone that we weren't able to see on the radiographs, our assumption is that this is probably a urate stone. And that ends up being a pretty educated, good guess for us. But now we need to deal with this obstruction. So endoscopically, we're going to go in and we identify our right UVJ, and we've placed our guide wire in there just like we did for our ectopic ureter, followed by our ureteral catheter. Next, we're going to do a retrograde ureterogram. Here's our rigid scope coming in. We have a marker catheter here, and that's going to allow us to do accurate measurements for measuring for our stent length. We've got our ureteral catheter in, and we're going to start injecting here. And this will loop through a few times, but what we're going to see, we see this big dilated renal pelvis here. We see the proximal ureter dilated, but probably one of the first things that might catch your eye is this big stream of contrast coming out the side here. There's some little air bubbles that are popping around in here. Those actually aren't stones, they're just air bubbles. And what we suspect is this was the region where that stone was lodged, and we likely got some pressure necrosis, and that's resulted in some leaking of contrast out through a hole in the ureter. But not a big deal, because ureteral tears are also something that we can also manage with ureteral stenting. So we're going to go ahead with that. Here we're placing our guide wire up. We've placed it past the obstruction and past the tear, and we're working on getting a coil up here in the renal pelvis. Not quite as nice a coil as I'd like, but it kind of comes up, coils back around and up to here, but I've got a nice secure amount of wire up in there. Once I have that there, now I'm going to place my ureteral stent, and this is a typical type of ureteral stent that we'll place. These are called double pigtailed stents for hopefully obvious reasons here. They have a number of fenestrations that go along these ureteral stents, as well as this is a hollow tube. So urine can flow both through the stent and around the stent. And in fact, once we place a ureteral stent, within a couple of weeks, we get passive ureteral dilation around the stent, and that gives us a much bigger diameter tube for things like stones to pass. And that can be helpful for us in relieving these obstructions long term, so we don't have to go in and take that stone out surgically. Now, this end of the stent has a little bit of a taper to it, and when we go and load this on our wire, this whole stent's going to straighten out. The taper end goes on first because that's going to go up and sit in the kidney. Different stents will be marked differently. This has marks that are at 5, 10, 15, 20, 25, and 30 centimeters. And most all of them will have this little black mark at the end, and some of those are radio opaque, so you can see it fluoroscopically. Mostly these are meant for guiding endoscopic placement, so we know as we're pushing this ureteral catheter out of our scope and up the guide wire and into the ureter, we know when we're getting close to the end so that we don't accidentally push this pigtail up into the ureter. Okay. And here's our friend Angelina, and we're placing this ureteral catheter. We've got that coil up in the kidney, so as the stent gets up and the top end of this gets into the kidney, it's going to start to form that pigtail coil around that guide wire for us. In a moment here, you're going to see our little black mark come in, so I know that I've got the stent up where I want it. We're going to start pulling that guide wire out, and you'll see the catheters, or the stent start to buckle here because it's no longer supported by the guide wire. I'm then going to push this end out of the stent. You'll see it pop away, and it's going to form a nice coil in the bladder for us. What we're going to see then is that this is our coil in the bladder, and this is one of my favorite sites. We can see urine draining out through the fenestrations here, so we know that we've got it in place. We've got good drainage going on. Here's our fluoroscopic look at it, where we have our coil up in the kidney pelvis. We have our other coil down here in the bladder. And the next day, this is another beautiful site. This is the renal pelvis the day after we've placed this stent. So we went from about 1.5 centimeters in 24 hours down to 0.5 centimeter, and eventually look for hopefully complete resolution of this. Now, in a case like this, what we're looking for would be to leave the stent in for maybe 6 or 8 weeks, get a chance for this to heal, get a chance for that stone to pass down. And the plan was to get this dog back in 6 to 8 weeks to repeat imaging, see where we're at, and see if it was time to remove this stent. Knowing that this dog's making urate stones, we don't want to leave a stent in because we can get stent incrustation, where we get mineral material that deposits on the stent and builds up. And so we're fully expecting to see the center back in 6 to 8 weeks, and that turned into about 3 years later. And when this happens in people, they have a term for this they call the forgotten stent syndrome. And in people, they see incrustation a lot, and so usually the recommendation is actually to either remove or replace these stents about every 6 to 12 months in order to prevent there being issues where there's incrustation and you can't remove the stent. And a lot of times people forget they're supposed to go back to their doctor and have this done, so they term it forgotten stent syndrome. So this was Angelina, almost 3 years to the day from when we placed this stent. We can see we've got a little bit of migration. We don't have as nice a coil up here, and there's a little bit more stent coiling down out into the bladder. And hopefully you can make out this faint mineralization around the end of the stent, and this is where it's encrusted. And based on the radio opacity of this, likely consistent with the urate stones that we thought that this dog had in the past, and fits with it being a female Dalmatian. So that all fits together. Now, our conundrum here is that if we've got this big thing that is now essentially a 1.5 centimeter stone, that's not going to fit out the urethra. And so we can't just pull this stent like we normally would. What we end up doing is going in. Here's a picture, or excuse me, a video of looking at the stent cystoscopically. You can see how it's made this big boot of urate stone around here. There's other parts of this where it's mineralized as well. And then we'll also see there's a fair bit of just urate stone debris sitting around down here in the bladder. Now we're going to talk a little bit more about laser lithotripsy next, but that's something that we used here, and we went in and we lasered all of this stone material off the stent to free it up so that we could endoscopically remove it. Now, before we started doing this, we were a little bit smart and we went ahead and pulled the rest of the stent out of the ureter to make sure that that would freely come into the bladder. What we didn't want to do is spend a bunch of time freeing up this end to find out it was caught up and we ultimately needed surgery. So we got that part free. We lasered this away. And this is the stent after we got it out. So this is the proximal end of the stent that was up in the kidney. We can see that there's incrustation with stone material along the shaft and the proximal pigtail on here. This is what's kind of left after we lasered apart the lower part. This actually broke apart when we went to pull this out. We thought we had enough stone material off, and so we pulled this end out first. This was still too big and broke off where we had weakened it with lasering. We went and lasered the rest of the stone material off and retrieved that. And then we did urohydropropulsion and got the rest of the stone material out. Now, the second case I'll show you real briefly here is a case of pyelonephrosis. So this was a dog named Lexi. It was a little bit older dog. I think she was 8 or 9 years old, female spayed, presented essentially for urosepsis. So was febrile, had a neutrophilia with a left shift, had abdominal pain, was azotemic. When we did ultrasound, we found this is the kidney here. This is all renal pelvis in the middle here, and it's severely distended and dilated out and contains a large amount of echogenic material, which is essentially purulent material. This is a big abscess. And when we follow the ureter down, we see a stone here that's caused obstruction. So this dog started with a pyelonephritis, most likely. We suspect that this may ultimately be a struvite stone, but we need a culture to prove that we've got a urease producing bacteria to help fit our diagnosis there. But they get this infection, they may form a stone. The stone then decides to leave. It obstructs the ureter, and now we have this closed infection in here. It's essentially a big abscess. It's like having a closed pyometra. But we don't want to just go in and cut this kidney out because there's still a lot of life in this kidney, hopefully. And so in order to save it, we're going to go in and do some interventional uroendoscopy and stenting. So here, just like before, we passed a guide wire first, endoscopically and fluoroscopically. We then put our ureteral catheter in and we pass it all the way up to the bladder, to the kidney pelvis. And then we're going to lavage this out. And you can see how much filling defect we have here. After we've done a bunch of flushing, things are starting to look more just totally black with contrast in here. This is the material that we're lavaging out of here, basically a big pus ball that we've taken out of this kidney. And once we're done, we place a stent in so that we can establish drainage. We know that it's not going to re-obstruct from stone material. Again, we get passive dilation of this ureter. That's usually going to allow any stones to hopefully pass. If this is a struvite stone, we get this dog on antibiotics and we've established urine drainage where urine's coming through and bathing those stones in a more acidic pH. We're able to dissolve those stones and are going to go away. And these patients, again, we usually get back in about 6 to 8 weeks. As long as they're doing fine, we reculture them. If we're negative or on antibiotics and the kidney pelvis is looking good, we go back in endoscopically, we pull these stents. We continue antibiotics usually for another couple of weeks after that, and then stop antibiotics, repeat another set of cultures a couple of weeks later, make sure that we've cleared things up. And these dogs do really well with this. And it's nice because we don't have to put them through surgery. We're able to save the kidney, and everybody's happy at the end. So Dave, I'll stop there to take our next set of questions.
Yeah, we have one question, and that is, do you need renal pelvic dilation to place a ureteral stent?
Not entirely. It's certainly helpful to have some degree of dilation there, and especially if you're new to placing ureteral stents. I think it's a little bit easier to manage getting your guide wire in there and seeing things. But we do also place ureteral stents when there's not dilation, most commonly when we're doing our idiopathic renal hematuria cases and we're doing sclerotherapy. Those patients usually don't have any obstruction, and so they don't have a dilated pelvis, but we put a stent in because after we do sclerotherapy, there is some risk of getting swelling of the ureter and creating an obstruction. And so it's totally doable to get a stent in those guys. Sometimes it's not sitting as pretty as you would like with a nice pigtail coil, but it's in there and it's effective and it does its job. And we're usually leaving those in for a couple of weeks and pulling them anyways.
Good. Another question is, when you're pulling the stent, do you use a snare, a basket, grasping forceps? How do you pull those out?
Yeah, great question. So we've used a combination of things, and some of it depends on the size of the patient and the size scope that we're doing. If we can get one of our larger scopes in, then we can get a decent size, either grasping or biopsy forceps. A lot of times we just grab it with that and pull it out. If we're doing, say, a male dog and we have to use our ureteroscope, then we're usually using a stone basket and snagging and grabbing the end of it. If we have a smaller female that we just can't get big enough grasping forceps in to get a good hold of the stent, then we'll also use a stone retrieval basket and catch just the end of that pigtail, cinch it up, and pull it out.
Okay, great. That's it.
All right. Well, then we will move on to our last section, which is going to be laser lithotripsy. And we'll just talk a little bit about urolithiasis in general and some of the stones that we commonly deal with. One of those being struvite stones. And the nice thing about struvite stones is most of these we can just take care of by dissolution. In the dog in particular, where 99+% of these struvite stones are due to an infection that got going with a urease producing bacteria, we get an increase in pH, and that results in formation of our struvite stones. It's easy enough with appropriate antibiotics and an acidifying diet in order to dissolve these stones. And to show you a nice example of this, this was a little dog that came to us, has probably a dozen maybe of these struvite stones in there. We're making an educated guess they're struvite based on the fact that the dog has a high urine pH. It's got an infection. In this case, they were cocci in there and ultimately shown to be staph, which is our most common urease producing urinary tract infection. And we treated this infection with proper antibiotics. We put this dog on, I think this dog was on SD at the time, but there's several diets that we can use. And after a month, we got the dog back in, re-radiographed, and everything gone. Now, the important thing I think with these is maintaining them on the proper antibiotics until those stones are gone. Remember that as those stones form, they track bacteria in the stone. And so if we treat them only for a short time with antibiotics, we'll clear the urine, but as those stones dissolve, they may release more bacteria and we may get an infection again. And we'll see that all the times in treatment failures that get sent to us where things were getting better and then they either got static or got worse again. And it's usually because we've got an infection that has come back out of those stones and caused those problems. And you can get some pretty amazing cases. This one, and ultimately I didn't get the, I don't have the set of follow-up radiographs from the referring vet, but this is a dog's got a pretty huge kidney stone, lots of bladder stones, and this took a long time, probably, I think it was at least 4 or 5 months on this dog. But with antibiotics and long-term acidifying diet, we're actually able to dissolve and get rid of all this dog's stone disease. We're real happy with that. Now, one of the things we have to worry about with a stone like this is that as it starts to break down, we could end up with it getting small enough to start passing and obstructing the ureter. And in those cases, we may have to consider going in temporarily placing a stent until we can get that dissolved and out of there. But some of those cases really can just be managed with that and don't need a lot of intervention to take care of things. It just takes a little bit of patience and a dedicated owner for those. Now, the next most common stones that we see are calcium oxalate, and those, along with urates that are a little less common, need to be mechanically removed in most instances. There are times where you can possibly dissolve urate stones. People talk about doing that. I feel like I've got bad luck because I've had much lower success rates with that than what are reported by other people, but it is potential to dissolve the urate stones. But for the large part, we have to mechanically remove these, and especially if they're in a place, even urate stones where they're causing obstruction, then we really are gonna have to go in and just mechanically remove those. So over the years, we've had a lot of different strategies for this. One of the easiest ones is using voiding urohydropropulsion. And the biggest questions that I get about this from practitioners is how do I know if these stones are small enough to pass out the urethra? Well, the easy way to do this is get an assessment of your urethral size based on what size red rubber catheter you can place. What's the biggest red rubber you can fit in there? That's going to be a little bit different between male and female dogs. Once you know what size red rubber catheter you can place in there, you take that French size. If you divide it by 3, you'll get the size in millimeters of that. So if I can pass a 12 French catheter, then a 4 millimeter stone likely should go through there. Once I know that and I look at my stones, I figure, well, everything looks like it's small enough to go. Then we're going to do urohydropropulsion. And key for this one, they need to be under anesthesia so you can relax everything, including the urethra, really well. You're going to fill the bladder with saline. Get your patient set up in this position. So not straight up and down. Notice the spine's at a bit of an angle, and that puts the bladder straight up and down. We jiggle the bladder here a little bit to get our stones to fall down to the neck of the bladder. And then we're just going to squeeze and express the bladder and try to shoot those out. Now, you do want to be careful about not overpressuring the bladder. You can rupture the bladder, and I've done that twice now in all my years of practice, so it does happen, fortunately not very frequently. So if you go to squeeze and urine starts coming and then abruptly stops, you may want to relax your hand because it could be that you've got a stone that's obstructed, or a bunch of stones try to leave at the same time. Sometimes you have to flush them back into the bladder, encourage them to come out one at a time. Now, obviously, this is pretty straightforward and easy with a female dog, but you can also do this in male dogs as well. Same procedure, only difference is things are shooting up this way. So we usually have somebody whose job it is to kind of deflect the urine stream so it's not hitting the person doing the expression, getting things caught in a bowl. Now, with if stones are too big for urohydropropulsion, then our next go-to for years has been surgery. Some of the pros of it, it's readily available. Most practitioners are efficient at doing this. It can be a fairly cost-effective procedure, particularly in general practice. It's good for any stone type. So it doesn't matter what our stone is, we can go and take care of it this way. Some of the cons of it, though, is we do have incisions, so we have to worry about healing and infections and so forth. We can get leakage from the cystotomy site. There is the post-op care that has to be done. And looking at studies of this being done even by boarded surgeons, there's about a 20% incomplete removal rate of stones. And so it is really important if we're doing anything really to take stones out, whether it's urohydropropulsion, if it's surgery, if it's the lithotripsy we're going to talk about. It's really good to do post-op radiographs and make sure that you got everybody out. And sometimes these stones hide in little areas, but we want to make sure we get everybody out so we can start with a nice clean slate. Now, one of the procedures that's come about that a lot of people like is this percutaneous cystolithotomy, which is a bit of a nice interventional endouroscopy. Wow, getting late tonight. Endouroscopy procedure that can be done. And this procedure is done by filling up the bladder with saline so that you can palpate it across the abdomen. A small incision's made, a stay suture is placed in the bladder wall to hold it up to the abdominal wall, and then a laparoscopic port essentially is placed into the bladder. Through that port, a scope can be placed, and then a stone basket can be used to retrieve our stones out. And if a stone's too big to come straight out through the port, then the whole port can be removed. If need be, the bladder incision can be extended a little bit to get the stones out. And here's some nice pictures from Dr. Berent's Veterinary Clinics in North America article from 2015, just showing that technique with a bunch of little stones in there. They're in with their stone basket. They can collect and move and remove these. Now, a couple of benefits of these. Obviously, we've got a pretty minimal little incision here, small incision in the bladder. But because we have the scope in, we can use the scope to actually look down the proximal urethra and look and see if we've got stones that have gone out of the bladder that we need to go collect that maybe don't flush back in very well, or get passed over by a catheter that we pass retrograde from the end of the urethra back up to the bladder. So it's a nice minimally invasive technique. It's great when we have a large stone burden in here. We have very big stones in here that we want to get out. Some of these stones you can actually go in with a suction tip and just kind of suction and vacuum them out, almost like cleaning the bottom of your pool. And that can work pretty effectively. Now, the thing I want to talk about tonight is laser lithotripsy, because it's actually one of my favorite procedures to do. I think it probably comes from playing way too much asteroids on Atari as a kid and really liking to blow up rocks and with lasers and guns and things like that. And the laser that we use for that is the homeomyag laser, and that's what's most commonly used in veterinary medicine. There's some other lasers that can be used that are used on the human side for this as well. Now, the difference between the holmium YAG laser and some other lasers for fragmentation is that it uses a photothermal mechanism to break up the stones. So a lot of lasers create a cavitation bubble at the end of the laser fiber, and that cavitation bubble ruptures and it releases a shock wave, and that's what actually causes fragmentation. The holmium YAG laser creates what's called the Moses effect. And so it basically parts the water at the tip of the laser fiber. That allows the laser energy to pass through the air more efficiently than it passes through saline, where that energy gets absorbed very quickly. So it allows to transmit that laser energy to the surface of the stone. That then heats up water that's trapped in the stone, causes it to expand, and that's what actually fragments the stone. And you can see this in this slow-mo video here. We're going to activate the laser, and you're going to see the stone just break apart there. And it's pretty cool and pretty fun to watch. We love getting our students in and our house officers and things in. We usually get quite a crowd when we're doing this because everybody likes to see a stone get blown up. Now, to show you some case examples of this is Lola, a little, I think she was 3-4-year-old Jack Russell Terrier that came to us. She had previously had some stones and had a cystotomy, I think a year or two before. On repeat rad, she had another large stone that had formed in there. And the owners didn't want to go through surgery again, so they referred to us for laser lithotripsy. This is a great candidate because we have a single stone. It's a little bit large, but pretty easy to take care of, and it's just one of them. So I'm going to go in there, blow that up, and take it out. Here's an example of doing this in this dog. You can see we've already created some little holes that we've drilled in with our laser. And this is going to be kind of the coup d'etat to the stone, and we're going to fragment it and break it into these pieces. Once we break this open like this, the rest of these pieces break pretty easily just with a few hits of it. And once we get done with that, we usually basket out the largest pieces that are in there. Once we know that the largest pieces come easily out the urethra, we can either basket the rest of them, or we can just do voiding urohydropulsion, try to get everything out in one big shot. And here's the pieces that we took out. Obviously, when we blow up the stone with the laser, we lose some pieces that we just obliterated the stone. So this is what we end up with. And this is a nice happy radiograph showing that our stone's gone. We've got a little gas bubble in there just from being in there and running fluids and getting a little bit of air in there. Dog goes home same day, no incisions, there's no bed rest, goes home and is basically a normal dog the next day. So this is a real great procedure for this type of stone. Here's another great example where this works well. This is a male dog. You can see over the os penis here, we've got this urolith that's got enlarged here. We also have some little friends in the bladder. If we look at the size of these look small enough we can just take them out with urohydropropulsion, but we got this big guy that got stuck. So what do we do about this? So only one option would be to pass a catheter, see if we can retropulse this stone way back into the bladder, do a cystotomy, and just take everything out. But since we have a laser and we like to play asteroids, we can get in here with our laser. We're going to take this stone and break it up. Once we've broken that up, we can see some stone fragments in the distance. This is damage that was there from the stone being lodged in the wall here. Most of the time that heals up and not a big deal, but we can sometimes see strictures with that. Once we've gotten the stone broken up into fragments, we're going to come in with our stone basket. We're able to grab that stone and pull those fragments out. Once we got these big fragments out, we did voiding urohydropulsion, and now we have everybody out in a pretty simple, quick procedure. Procedure like this, maybe 30 minutes. That first case I showed you, maybe a 20-minute procedure. Again, no incisions. They go home. By the next day, it's like nothing happened, and these patients are pretty happy. Now, we'll talk about cats in a minute when I talk at the last slide here, but I just want to show you some other species we've done this in. This was a rabbit that actually had a cystotomy a day or two before, and then was found there was still a stone in there. So we're able to go in, rather than having to take this bunny back to surgery, we just went in and obliterated the stone and fleshed the pieces out. And so we didn't have to go back to surgery, and so everybody was happy with that. This is, and if anybody's kind of a zoo or wildlife vet out there, this is an Asian small claw otter. And we have a couple of these that came as a pair to our local college teaching zoo, community college teaching zoo. And if you're familiar with these at all, you know they're notorious, the captive Asian small claw otters, for getting calcium oxalate nephroliths in here in their kidneys. This guy also had one big stone in here. As well as his sister also had the same thing. And given that these guys spend a lot of time in the water, they're essentially wild creatures. So trying to manage an abdominal incision, these guys would be a bit of a nightmare. So they brought them over to UF. We were able to go in and do laser lithotripsy and break up the bladder stone. We're not able to get to the kidney stones with this technique, but we could blow up and remove this bladder stone and get it out of there. They're able to go right back in their enclosure, go back to swimming in their pool like nothing happened. So it was a real win-win situation for everybody there. The last one I'll show you is horses, and we have done some horses over the years. The horse stones are a bit problematic. Some of them are easy to break apart. This one was a calcium carbonate stone that had the right conformation to it. We start with this big stone, and this is crazy because we're actually in here with a gastroscope up the urethra in this mare to get to the stone. This is where we got most of it broken down, and it was small enough at this point that one of our large animal clinicians actually just went in with her arm all the way up the urethra, grabbed the stone and pulled it out. And I was quite jealous because there was many a times I had wished it was that simple to pull stones out of our patients' bladders. And you can see kind of the pile of rubbish that we removed out of here in this chunk of stone as well. And so this avoided any type of surgery in this horse. We actually did this as a standing procedure. We have had other horses with calcium carbonate stones that have a different matrix to them, and they don't break very easily. And those stones usually have a lot of crevices and cracks in them here. And they really just don't break down very well. And we spend a lot of time trying to break them and trying to break them and try and break them. And it's almost impossible for some of those, and we just have to give up. So it is a potential option. If you got smaller stones that are causing ureteral obstructions, you can get up the ureter in the horse and potentially do lithotripsy there as well. So what do I consider non-candidates for laser lithotripsy? Well, those with really large stones. So this is not one, even on my best day, that I would consider trying to go in and do laser lithotripsy on, because that's about a 6-day job there. If we've got a really huge stone burden, then I'm also not going to do it either, because the amount of time that I would spend doing that, it's way quicker to have one of my surgeons unzip the bladder, take everything out, sew it up, and be done with it. And so it's really about picking the right cases for this. Females are certainly a lot easier than male dogs. Male dogs, we have to get a endoscope there, so we're using a small ureteroscope. We're having to navigate a long, narrow urethra. So especially getting stones out of the bladder, when we have too many of them and they're too large, it's really just, it's not a very fun procedure to do. If we can get them lined up in the urethra and just blow them up and pull them out of the urethra, then we're in good shape. I'm always looking at the time component of it. How long would it take me to do this versus how when the surgeons do a percutaneous cystolithotomy? You know, if they can, you know, if it's going to be a 2-hour job for me trying to laser and get something out, I'd much rather just have the surgeons make a small incision, grab everything out and be done with it, unless the owners really push me for it. Cats, male cats that haven't had a PU are definitely out for us. Female cats, we'll sometimes do those, but I think a lot of times the PCL tends to just be quicker, just because the stones in there are usually big enough. It's going to take us a while to break it small enough to get it out the urethra, but we have from time to time done cats as well. But most of the time I just send those for a PCCL because it can just be done a lot quicker and less trauma to the urethra. Before I take questions, I do just want to make a small plug. As Dave Tweet mentioned, I am president currently of VIRES, and we just kicked off our VIRES meeting in conjunction with the Vet Meet Summer Camp. And Vet Meet's a European radiology group, an imaging group. And we kicked that off on Monday, and we're running a virtual conference right now that starts on Monday, runs till July 9th. If you go to vetmeet.com, you can find out more information and register for the conference. And we'll have a lot of pre-recorded material, and then not next week, but the week after, June 28th, that week, we'll have some live sessions with Q&As based on those topics as well. So if you've enjoyed what you've seen tonight, if you're real interested in it, want to learn more, please join us for the virtual conference. Also feel free to join our society, our Veterinary Interventional Radiology and Interventional Endoscopy Society. You can find more information about us at vires.org. With that, thank you guys for listening. I'm happy to take some final questions, Dave.
Yeah, we have 2 questions. I think you've actually answered one of them, but one is, how long does laser lithotripsy procedures take on the average for dogs? In your hand.
Yeah, a lot of this is picking the right cases. I'd say if we choose the cases right, I usually try to pick a case I know is probably not going to take me longer than like 45 minutes to maybe an hour with it. So I kind of artificially pick ones that are going to be in that time frame. We certainly had cases we thought were going to go smoothly, and we got in there, and we were in there for 2 hours or so. Those are usually ones I go back and look at and say, well, what could I have seen that may have predicted we were going to be a 2 hour procedure? And maybe is that one I should have just done surgery with? But we do occasionally get owners that really just want us to do that. They absolutely don't want surgery, or the dog's had multiple cystotomies already, and they don't, either don't want to do one, or the surgeons sometimes come to us and say, we're not doing another cystotomy. There's too much scar tissue for us to deal with. And so we'll go in, even if it's a longer procedure, and do it. But most of these I'm looking, a lot of the females these days I can do in about 30 minutes, male dogs 45 minutes to an hour, depending on the
Is
bird.
there a basic rule on the size of the stones that you will not go over?
A little bit. So for female dogs, usually my rule is if it's a single stone that's less than 2 centimeters in a reasonably sized female dog, I'll usually go for it, because I've gotten fairly efficient at the lithotripsy of those. If there's multiple stones, I usually say I'm not going to do more than, if there's more than 2 or 3 stones that are a centimeter or more, I'm probably not going to do it. In male dogs, I get a little more choosy. If I've got a single stone in the bladder that I think won't take me too many hits to break up, small enough to get out the urethra, I'll do it. If I get more than a couple of stones that need a lot of lasering, and I think I need a lot of lasering in the male dog bladder, I'm not going to go for it. It just takes a lot of time. You're a lot of in and out trying to get pieces out and things. It's just so much quicker and less damage to the urethra to just do a cystotomy or a PCCL for that. If they're in the urethra, really any male dog with a urethral stone, as long as we don't have some reason we can't get the endoscope to the stone, then those are all kind of fair game for me.
Great. Thanks a lot, Alex. This was a great presentation.
Oh, thank you. Thank you guys for having me tonight.
Yeah. So once again, I'd like to thank all of you in the audience for attending. So we'll resume our normal endoscopy talks in July 14th. And Dr. Gran from France will speak on how to avoid and minimize complications of arthroscopy. So we look forward to seeing you then. And in the meantime, wishing you all the very best. Thank you.